Namaste, everybody. Respected teachers, senior colleagues, and friends, good evening. Wish you all happy, healthy, prosperous, and peaceful New Year. Wish you all task-free and endophthalmitis-free New Year as well. As you are aware, we had recent outbreaks of TAS in various parts of India. To address this important issue and to gain knowledge about TAS and standards of care which we must take for sterilization of equipments as well as cleaning of equipments, we at Maharashtra Ophthalmological Society have organized this webinar, Safety First. In fact, this is a brainchild of Dr. Anaga, and she has taken a lot of efforts for this webinar. And we also have circulated a form, Google form, to all the members and done the survey as well. We are fortunate to have world-renowned eminent faculty for this webinar. And I would request Dr. Anaga to introduce our faculty for today.
Thank you, Dr. Santosh, for the kind words. And at the outset, I'd like to thank each one of the panelists for taking out time from your busy schedule and being here with us to guide us through our webinar. We have a galaxy of super speakers, I would say, and this webinar would like to address all the concerns and doubts that ophthalmologists have in their mind in recent times, especially with a lot of incidents of TAS going on. So we would like to welcome each one of our faculty, to start with Dr. Lalit Verma sir, our charismatic president, AIOS, and he's the director of vitreoretinal services of Center for Sight. And he's been very actively involved, especially in the last few weeks, in motivating all of us to gear up and to be more careful and take more precautions. Professor Namrata Sharma ma'am, our dynamic secretary, AIOS, and a role model for all of us. And they were both, I think, part of the leading the AIOS task force, which had guidelines to prevent TAS and endophthalmitis, I think, which was also revised in 2018. I'd like to welcome Dr. Professor Mahipal Sachdev sir, our immediate past president, AIOS, who had been the guiding light and at the forefront during our difficult COVID times. And he's the chairman and medical director of Center for Sight Group of Hospitals and a true inspiration for all of us. I'd like to welcome Dr. Professor T.P. Lahane sir, who is the Professor, Regional Institute of Ophthalmology, GMC and Sir J.J. Group of Hospitals, founder and chairman Raghunath Netralaya Eye and Research Institute, coordinator for the Preventable Blindness Mission of Maharashtra, an amazing surgeon and a great teacher. I'd like to invite Professor Jeevan Singh Titial sir. He is the Chief RP Center for Ophthalmic Sciences, AIMS, New Delhi, and with his years of expertise and experience, he's been truly the guiding light for all of us. Dr. R.D. Ravindran sir, we welcome you. He's the Chairman, Director, Quality, Arvind Eye Care System, and he's been a true inspiration for all of us, and with his years of experience, we are sure he'll give us absolute pearls of wisdom today. Welcome you all, sir.
We also have Dr. Savitri Sharma Madam, who is the Director Emeritus of Laboratory Services at L.V. Prasad Eye Institute Network of Hospitals. Way back in 1986, she has established ocular microbiology services at Arvind Eye Hospital, Madurai. And since 1991, she is working at L.V. Prasad Eye Hospital. An institution has named Chair of Ocular Microbiology in recognition of her services. We also have a brilliant surgeon, Dr. Haripriya Madam, who is the Chief of Intraocular Lens and Cataract Services at Arvind Eye Hospital, Chennai. We have Dr. M.S. Ravindra from Bangalore, President of Bangalore Ophthalmological Association. He has a vast experience in the field of ophthalmology of last 41 years. He is a Chairman and Medical Director of Karthik Netralaya. Dr. Nirmal Frederick, a good friend of mine, he is a Principal Assessor of NABH. He is the incoming President of Tamil Nadu Ophthalmological Association, and he is also a Managing Director at Nirmal Eye Hospitals. Dr. Deepak Megur, a brilliant surgeon with a lot of videos on YouTube channel. He is from Megur Eye Hospital, Bidar, Karnataka. And we have our own Dr. Saurabh Patwardhan, who is again a brilliant young surgeon from Sangli, and he's a Medical Director at Nandadeep Eye Hospital, Sangli. So we have a galaxy of faculty. We have 3 Padma Shri awardees in our faculty. So I'm sure that we are going to gain a lot of knowledge regarding how to prevent TAS and how to prevent endophthalmitis. So I request Dr. Anaga to start the webinar.
Yeah, thank you, Dr. Santosh. And just a small bit of introduction. In fact, when we decided to do this webinar, there were so many things that we wanted to include. So we have divided into two parts. The first part today will deal with everything that enters the eye, including the phaco tips, the tubings, BSS or the RL, the blades, instruments, and everything related to sterilization and cleaning protocols. The second part, which will be held tomorrow, will deal with the operating room related issues, the cleaning protocols, as well as the patient related issues. Now, in order to understand the practice patterns among all us ophthalmologists, we through MOS decided to do a survey, the results of which I will just quickly share now. I'm just sharing my screen. Is it visible?
Yes, it is visible.
Yes. Yeah, so this was a survey which we had done, and we had almost around 450 responses. But since we have taken it from today, this was today afternoon, it was 437 responses. So more than 70% had been in practice for more than 10 years. More than 70% had a private single OT, and around 11% a single opthal institutional OT. When the question how frequently you change keratomes, side port blades, and crescents, you can see almost 70% after each case, 16% after 2 cases. Regarding the frequency of changing tips and sleeves in the OT, around 45% after each case, and almost at 26% after the end of OT. Regarding frequency of changing the IA, the bimanual or Simcoe or coaxial, again, around 25% were at the end of OT and almost 55% after each case. Regarding the type of autoclave used, around 51% were the vertical steam and only around 15% the horizontal steam and 30% were the class B autoclaves. Regarding the use of flash autoclaves, 87.9% did not use. And these were the types of indicators that were used, almost 22% class 1 and 27% class 5, 13% class 6, and then some used also a combination of the two. Regarding the fluid that was used to clean the phaco handpiece and tips, there was around 69% with distilled water, 16.9% RO water, and 11.9% RL. Regarding preference for cleaning shafts and cannulas, tap water was used in 36.4%, 37.1% used non-enzymatic liquids, and 20% betadine low concentration. Drying of instruments, 52% by blow dry, 27% by tissue paper, and 20% used air pumps. Almost 50% used ultrasonic cleaners, and almost 39% used RL. Autoclaving irrigating fluids, 7%. Regarding ETO of the phaco handpiece and tips, almost 83.5% did not ETO. Only 50% of people are using intracameral moxifloxacin, and some of them directly from the eye drop and 12% diluted from the eye drop. Others are using pre-filled. And these were some of the other protocols that they had shared with us. So since there were a lot of concerns and doubts and apprehensions regarding all this, the reason why we took this survey was to understand what is happening across the country. We are still getting responses. So before we start the first question, I'd like to ask our President AOS, Dr. Lalit Verma, sir, to just say a few words before we start our first question. Dr. Lalit Verma, sir, are you here?
Yes, Anaga, I am here. I was listening to your survey result only. Must congratulate MOS for taking this giant lead, as Titial was saying, to begin this new year, so that we don't face all these issues. You see, I have, I joined this, task registry group on WhatsApp slightly late, but as soon as I came to know, we at AIUS, swung into action, complete action. And me, Namrata, Rajesh, everybody used to have meetings virtually every day, even though I was traveling, but still I remember, Dr. Mahipal and Dr. Chetan, they helped me a lot in this. And we, on Christmas Day, Namrata convened that meeting of AIUS, looking forward for this. And you see, purpose there was not to present lectures on TAS or not to, present lectures on endophthalmitis, but what should be the way forward? Because single thing which was pinching me as President AIS was that, you see, we as doctors do the best for the patient, but why should we be held responsible for no fault of ours when a patient develops, say, limbus tuberous corneal edema or hypopyon, whereas we were expecting, 6 on day 1. And that was a very emotional actually reason for me. Although you see, I'm not an anti-SME surgeon, but if any member of mine, or that is AIUS, faces a single reaction also, I become very, very sensitive and emotional. And believe me, that is what propelled me to, and I had a talk with Anaga, I had multiple talks with Dr. Santosh Bhide also. So I told him that AIUS will not be a mute spectator to all this, fallacies of fluids or phaco's or, IOLs or all these things, but we will immediately take anybody, whosoever may be, to the task. And that is when I think we swung into action. I will just tell you a couple of points only. I will not take much time, Anaga. I know there is no presentation here, but still just let you know that what we as AIS did immediately, and today also. You see, today also we were there at AIS office, hence we got late. This is what you see. This was the looking for way forward. This was the list of first communication which we had sent on 19 December, which Namrata had sent this mailer that these were the batch numbers at that time. This batch numbers, in fact, I know continue to increase. And this was the batch numbers communicated by the care group, and this was the batch numbers which I gathered from the Dr. Chetan Parik, who was kind enough to accumulate all this data. Because important is all the members should actually accumulate the data so that we can represent to DCGI. You see, job of AIUS is to sensitize the FDA of India. And this is a survey form which Namrata had designed and put it on the website. And we did, took cooperation from all the MC members also. Because as you know, all the states have all these members who helped us. And this was the way forward meeting which we had on 25th of December, Sunday at 11 o'clock. And we did have a lot of, positive kind of response and directives from the respected members who had joined on that day. And this was the list of batches again. And the task survey also was done. And this is today's photograph. You see from 6 bags we prepared from various, places in India where we got samples from. We have already sent this to the laboratory today. And also this registry, which, Dr. Mahipal and a lot of people had requested on that day, that AI should have a permanent registry on the website. And not only TAS, but we are going to make it a, 365 days a year. Any member who experiences any kind of reaction with any kind of, substance or lens or fluid or injection, whatever, we should be, proactive in filling up all these things. And our report, which is sent today, will come in a day or so. And before we meet in Patna, I think Namrata will be ready with this report. So this is what has been sent. So I'll stop sharing here and congratulate, Dr. Santosh as well as Anaga for making us all aware. In fact, making us AIS also aware of these things. And we will, as I said, take this forward. And thanks to you for arranging today this interactive, discussion without any, any presentation. This is what is required. We don't want to educate all these learned people about TAS or endophthalmitis. We will have practical discussions like how to clean the tubing. Like you yourself, Anaga, was saying, there's no uniform this thing. Some people, 45%, 75% are doing day 1, day 2. And I believe that we have to have a focus group meeting in Namrata so that we standardize all these protocols. You see, we may differ, but ultimately AIS, we should come out with standard kind of guidelines where they advise all these members so as to have a standard protocol, which is advocated by the members, by the majority of the members, so that we have a uniform kind of, approach to, so that we can prevent. Thanks, Naga, for tolerating me for 5 minutes.
No, sir. Thank you so much for your guiding words. So we'll dive in right away with the questions. So our first question is to Dr. M.S. Ravindra, sir. Sir, we would like to ask you regarding the phaco tips and tubings. I think that is the most commonly used and the most important instrument that we have that goes into the eye. So please let us know what is your protocol of cleaning the phaco tips and tubings.
Anurag, I will take 1 second or more. Namrata, I will request that you please keep noting all these points, what everybody says, because I may be off for some time. I will rejoin again after some time, because in the meanwhile, Namrata will keep taking all these points so that we make list of all these points from all the learned speakers, and so that we can, have some homework to do also.
So we
Thank you.
have meeting recorded, so
Recording,
we
we
will
are
share that
recording.
recording to you on your
Okay,
personal-
And
okay.
it is on
Then-
YouTube. It will be on
Okay,
YouTube.
it is on YouTube also, but we will share that recording also.
Okay, thank you.
Anaga, thanks for asking me this question. I am of the firm opinion, just like my mentor, Dr. Badrinath, taught, that everything that's used in one surgery needs to be changed. There's no questions asked on this. Whatever I use for one surgery completely is changed, and I come back with fresh autoclaved tips, sleeves, cable, the tubings, IA probes, that's the ideal way of practicing. I know that the practice varies from place to place depending upon their experience and their nose. But to make it very short, I would say everything is changed. And once I would like to buy a machine which is compatible for this. Some of the modern machines which work extremely well. They are supposed to be changed there too, but for cost saving, people have been reusing it successfully, I would say. But logically speaking, we need to change everything from A to Z. Cleaning wise, the companies, every company has given some protocols, and the best is to ask the company, website. You can check it or ask the representative how to clean it. Generally, it's distilled water or RO water that's used to flush the cannulas and the phaco tubes and phaco probes, and then the IA probes. 150-200 ml has to be pumped through it. Mechanically pushing water is very difficult. 50 ml syringe people use to push it, but best is to have an automated version. I have a water tub with a DC motor inside, and the pipe comes out. That continuously flushes water through tubings. It makes life very easy, and then you roll it up and autoclave it. One thing I would like to say here is any instrument that used in the eye should not be stored for a lengthy period. So the best is to the technicians who assist us and the technicians who clean the instruments have to be separate. The moment the instruments are shifted to the processing room, the cleaning process has to start, because more you wait, there is a degradation of protein that is left behind either from the aqueous or from the lens or from the tear, whatever it is, and that will start activating the proliferation of bacteria. Bacteria proliferate phenomenally. So it has to be started, the process has to start right now. And at the end of the day, I would insist that no storage of wet instruments or even hand-dried instruments or towel-dried instruments are kept overnight, because that moisture will multiply the organisms. So everything has to be absolutely dry when you store them at night.
Yes, sir. Dr. Haripriya ma'am, I wanted to ask you one question. There was this article by Dr. David Chang where they have given guidelines for cleaning and sterilization of instruments, where they have also mentioned about Arvind Eye Care system. And they have said that if there is cost effectiveness, even if you have used the phaco tips for a few cases, say for 2 cases or 3 cases, in between cases, on table, do you need to flush with RO water or distilled water? And what is the difference between distilled water, RO water, and which would be preferable? And in your institute, what protocol do you follow also regarding the cleaning protocol in between cases, and yes, at the end of the session?
Yeah. So I think again, thank you for having this webinar, Anaka. So the phaco tubing, I agree with the Ravindra sir. All the tips which are used in surgery, once we use them, we only use it again after it is re-autoclaved. So we do either flash it between surgeries or it has to count. So after we finish surgery, we don't clean the tips on the table because that is a sterile zone. We send out, each set is sent out after surgery, and immediately once it's received by the CSST staff, they will clean. So we normally use RO water. So reverse osmosis water, we use the ultrafiltration is used, about 0.2 micron is what we used. And the difference between RO water and distilled water, RO water basically is filtered, and you also have some minerals added to it towards the end, whereas in distilled water, that doesn't happen. Now, once the surgery is over and the tips are sent out of the OT, we have them flushed. So our standard is we flush all the phaco tips with a 10 ml syringe. We just clean it out once. End of the day, we use a larger cannula. We use a 20 ml syringe, and we use it about 5 times. We flush the whole tip and then send it out for the autoclave. This is the process which we do for the
And again with air also to remove after the
end of the day. Yes, end of the day we also remove the air and then we send it out to the autoclave.
Would anybody like to add anything in this, Dr. Maipal sir, Dr. Savitri ma'am?
So actually, what has been said is correct. The only thing is that we do not change the cassettes and the tubing in every case. So that's something from a cost effective. I don't know whether you do that in Arvind or other places. I don't know, but
yeah, we don't change them too, sir. Yeah.
So because the
So
set
how
is
many cases you use one cassette? Single cassette for how many cases?
It's per session, I would say, like a session could be about, so it depends on who the surgeon is, how fast he's doing. But basically, we use it for a session. I think RP Center also does that.
Yes,
We don't reuse them, we don't ETO them. And that's from the.
I think so. For fast surgeons like Dr. Titial sir, it would be 5 to 6, if I am correct, sir, 5 to 6 cases per cassette. And for surgeons who are residents, etc., it would be like 3 cases per cassette.
At Arvind, we don't change the cassette.
Yeah.
Till the end of the day. Yeah, we use the same cassette for the entire session. Yeah, for the entire
Yeah, that's what I said. We also use it for the session. That's what I meant.
The tip you change every case, or tips
If
also?
we change sleeve, we change. That's not an issue because you can have lot many tips and sleeves that are there. And otherwise, obviously, it does not become viable in case you are spending 3,000-4,000 rupees for the entire this thing. And if you have that becomes a challenge. But technically, if you are looking, if the bottle you have checked and if you have said about the fluid, etc., that's going into the eye and the tip and the sleeve, I think the fluid in itself, if it is of good quality, that should not cause any problem, I suppose. And I think
I think it is important what we talk about in terms of changing the cassette. We look for around 70% fill of the bag. Once it is around 70%, we change the entire cassette. We should not wait for beyond 70%. The effectivity might be a concern there. As far as tips are concerned, we do, as rightly pointed out, tip and sleeves are changed every case. And one tip goes for around 10 cases. And sleeves are changed as soon as they are torn or not more than 5 autoclaves because they don't last more than that. So sleeves are for 5 autoclaves and tips are 10 autoclaves.
But in particular session, handpiece, how many times you change? Or you keep the same handpiece for 5 cases and just change the
It depends on which OT they are. In my OT, I change handpiece after every 7 cases. I use around 5 handpieces in one OR. So that is changed. Otherwise, in the general cases, they go on for an entire session sometimes.
So we also
Lahane sir, can you comment on this? Professor Lahane sir.
Last time also there was a meeting, and it is a very practically difficult that for every case to change the probe. It is not possible. Now to change the probe after 7 cases or after 10 cases, that is also not good. So that time it was decided, resolved that the probe should be changed after 5 cases. Yes, the tip, if you want, you can change the tip for every case, or minimum sleeve we should change, because tip, whenever you are using the tip, that time because of the, you can say, high pressure and also the temperature, that gets sterilized automatically. But the sleeve we should change. And if patient is having something, that we'll have to classify the patient. If patient is having some infection or conjunctivitis or iritis or like that, so we'll have to classify the patient. And those patients can cause the infection, we can keep them last. And the clean patient we can operate, where we can operate 5 cases. About the cassette, yes, total session, we use only 1 cassette. We are not changing any cassette, and that is not practically possible. So complete session in the morning we are starting, and up to evening. Now I do sometimes I do near about 50 pepo, but there I change my pepo, the sleeve for each and every person. And tip I change after this tip is there for 5 cases, and after 5 cases I change the probe. So that is what we do. And in I think with the touch wood, up till now we are operating 120 or 150 pepo every day. So there is no task also in JJ hospital. But yes, we are taking the task from outside coming patients, and we have now treated there about 63 cases of tasks coming from Maharashtra and outside Maharashtra. That strategies I will tell you when we are discussing what is the cause of the task. But this is what we are doing, and I think that is only feasible. Yes, those who are doing less surgeries and in private, they can use the you can say phaco probe separately for each. But I want to tell you another thing. There are 6 cases just now. There is endophthalmitis in Mumbai in one doctor's place. He used that phaco in the morning 3 cases, in the afternoon 3 cases, but phaco probe was autoclaved yesterday. So while the Rendran sir was telling that washing the phaco probe after the surgery is very important. All the instrument equipment what you have used that day, you should wash it properly, autoclave it, and then go home. And second day, that session should not be used. Second day, again you autoclave before that, and then you use. If you are using after 12 hours, I will tell you, in the morning, he has got the infection, same probe, it is pseudomonas, but mild. All 3 cases, one is 612, one is 3/60, and one is other is 660. But in the afternoon, the other probe he has used, but as the driver was saying, the colonies they grow. After 24 hours, he has used after 3 p.m. All has got the cornea, you can say the very bad cornea, and they have got the pseudomonas, and they have replaced cornea in 1%. So I think this is the colony which was grown. So that is example that yesterday you are doing the sterilization, which should not be, it should be on the same day. And if you are operating in the morning, he was telling me, I operate in the morning, then I should cancel this. He said, no, you can start at, instead of 8, start at 9, but do the autoclaving on the same day. And even the washing, yes, we can go for the RO water. It is not possible that everybody has the RO system. But few people, they can also use the distilled water. And also, we use 20 ml syringe and wash 5 times, and then dry wash with the air. So that we are doing in JJ.
What
Dr.
about
Sai-
eye handpiece or eye bimanual eye? You change every case or you change after 5 cases?
Bimanual eye we are not using because of this only. We are using this AC maintainer and this aspiration cannula, which is separate in each and every you can say our set. So 300 rupees for the AC maintainer, 300 rupees for the aspiration cannula, and that is separate. We are not using eye at all in JJ hospital.
What about TTL, sir? What is your opinion? And Dr. Mahipal,
No,
sir?
we change the eye handpiece after every case. We use coaxial eye for most cases. Those people who is bimanual, that is also the steel one, and that is also autoclaved after every case. And as far as handpieces are concerned, we don't autoclave the handpiece. We have enough sets. They are plasma sterilized and used for the session. Otherwise, the life goes. Autoclaving is a major concern there.
Yeah, same
Your
thing we
opinion.
do.
Yeah.
Same thing we do. The handpiece is plasma sterilized, and every case will get an autoclave.
Madam, your sound is breaking.
It is not stable.
Maybe it's not, the net is not stable. Maybe you can switch off the video so that we can't hear you properly, ma'am.
tip and sleeves.
Can you repeat, madam, because we couldn't hear properly.
Okay. Can you hear me now?
Yes, madam.
Can you hear me now? Can you
Yes,
hear
better,
now?
better.
Yes, madam. Yes, madam.
No?
Yes,
ma'am.
yes, we can hear you clearly.
I can hear all of you.
Can hear you, ma'am. Please go ahead.
I can hear all of you. Yeah, so what I was saying that we do the same, the handset we use plasma sterilizer, and for every case autoclaved tip and sleeve is what our recommendation is to use.
Ma'am, Dr. Lane sir was saying we need
Did
to.
you hear?
Yes, yes,
Yes,
ma'am.
yes.
So, what is the ideal time interval between the autoclaving and the use actually? What should be the ideal time? And not more than how
We
many
have
hours
kept
you
it as we have kept it as 24 hours.
24 hours. Okay, because
24
usually,
hours. If you're next day you autoclave again.
Dr. Ravindran sir, I wanted to ask the same question to you. Suppose we have a case the next morning, in the morning, say around 8 o'clock or 9 o'clock, then do we need to autoclave it just 1 hour, 2 hours prior or earlier day? What is the protocol in your center?
Yeah, see, it depends upon your OT. Can you hear me?
Yes,
Yes, sir. Yes, sir.
It depends upon your OT protocols. If you're packing individual sets in double wrapping, and if you have a B class autoclave which dries the instruments completely at the end of the cycle, there's no need to do it on the same day. You can as well take time. My limit is actually 2 days time, not 24 but 48 hours. So we generally prefer to autoclave soon after the surgery on the same day in the evening, so that no instrument is stored wet or moist or in the crevices in the tubings. Some amount of moisture can be there. Bacteria multiply in these areas. So I would prefer to do autoclave at the end of the day, so that you remove all the moisture and you sterilize these things. And they're all in individual packs, so that you don't have to worry. Next day morning, you open it up and use it. But if you do not use a B class autoclave and instruments may remain a little moist at the end of the day, then what is told is very applicable, that you'll have to do it as close to the surgery as it's possible.
Yeah, that brings us to the question regarding which autoclave is the best. Dr. R.D. Ravindran sir, so is B class autoclave essential, or as we saw in our survey, many of the ophthalmologists are still using the vertical steam autoclaves?
For sterilizing tubings, can you hear me now?
Yes, ma'am.
Yes,
Yeah.
ma'am.
For sterilizing tubings, definitely the B class. By B class, you mean vacuum autoclaves, right?
Yes, ma'am.
The one which will remove the air
Yes.
from inside, yeah, and then fill it up with steam. Whereas people who are using vertical type of autoclave, they will not have this, and a lot of moisture will remain inside the tubes. Even if you have used the air gun, you may not be able to remove everything. So if one can afford, it's definitely better to have vacuum sterilizers or B class sterilizers, autoclaves.
I mean, we also feel it's important that we use this B class autoclaves because of the tubing and cannulated instruments. So the last 5 years we have switched over to this B class autoclaves in all our hospital, including the secondary centers. So I mean, and coming back to the first question, normally we keep it for like 24 hours. Anything that is autoclaved, we usually store it in a surgical bin, which is covered. So that's what we use, and it is used for about 24 hours.
Dr. Saurabh and Dr. Meghur, your opinion both. Yeah.
Yeah, Deepak, yeah. Unmute.
So I just wanted to clarify the common misconception about most ophthalmologists about B class autoclave. See, there is only one autoclave which is called as a vacuum sterilizer. So we have a pre-vacuum sterilizer and a post-vacuum sterilizers. So these are the one which are supposed to be used for hospitals. B class is a variant. A tabletop variant of this vacuum sterilizers is referred to as B class autoclave. It is nothing different, okay? All big autoclaves have this pre-vacuum and post-vacuum system. A vacuum pump is there, which is used to suck in the air which is trapped in the cavity of the autoclave. So B class is nothing magical. It's just a tabletop version of these autoclave is called as a B class autoclave. In India, the tragedy is we have never been understood about this concept, and we always thought autoclave always means a vertical bin and keep this. The principle of air removal system has never been taught and taught to us, or we have not understood it. But classical thing is most hospital autoclaves are supposed to have an active air removal mechanism, which is built into the system. So all bigger hospitals are supposed to have this. So if you have most of the expensive autoclaves in all the bigger hospitals is pre-built. So air removal mechanism is pre-built into it. B class is just a tabletop variant of it. So even if you buy a horizontal autoclave, which is from a good company, and if you ask them to fit in a vacuum pump inside, all the pre-vacuum and post-vacuum, these features are available in those as well. Okay, so the B class is just a tabletop variant of these sterilizers. So basically it is used for smaller setups, like, 3-4 sets you want to do. The limitation of a B class autoclave is the space is very limited. You can't autoclave more than 3 sets or 4 sets and all those things. So for individual practitioners and all those things, that's fine. But whose volume is very high and who have lots of things, so they may need to have a bigger sterilizer system. So all sterilizers with built-in pre-vacuum, built-in vacuum to remove this air, that is critical for ophthalmic setups. I think this is principle we need to have a clarity in our mind, because in ophthalmology, most of us, all the devices are cannulated, hollow devices, and air which is trapped inside these devices is extremely difficult to remove by just passive steam. So we need to have an active air removal mechanism, whether you have a large sterilizer with a vacuum system or a tabletop B class variant is also fine. Second important thing is all not B class autoclaves are same. You need to validate them whether your machine is functioning properly or not. So just buying a B class autoclave and assuming that it is working properly is again a major fallacy. So the ophthalmologist should be aware of how do you validate your system or your autoclave.
So does that mean that the vertical autoclaves are useless and it should not be used?
No, yeah, but that only we came to know when we started validating them. So we did this test in our center, we did in 2008 and came out that most of the vertical autoclaves are not suitable because they couldn't pass that helix tube PCD test, the process challenge device which is required, which judges how you were able to suck out the air. So this is what the study which we did way back about 12, 13 years back. And we found out that most of the autoclaves which don't have an active air removal mechanism, they can't remove air from a cannulated instruments. So that's the reason they are not suitable. They're perfectly fine for just your linen solid instruments like scissors, your forceps, they are perfectly fine. But for hollow instruments, to remove the air, they're not good enough.
Yes.
So for tubings, it is not good.
Yeah, because these B class, what you mentioned, so rightly, they're mostly in 21 liters and only one company has a 48-liter one. But the 21 liters, it is so small that you're not able to cater to a higher volume.
No, in Western countries, you got large autoclaves, like, they have got 500 liters and everything, but all of them will have a built-in vacuum system. Okay. The principle of sterilization always is first air removal mechanism has to be there. So you got 500 liters also, 1000 liters also. They're all used in Western countries.
For us,
in our countries, we are not aware of it, those things. That's the only limitation.
So Dr. Saurabh, if you have say 10 cases, you have a very high volume practice. So what is your way of doing this?
Doing which sterilization for the phaco?
Yes.
For the tubings or phaco tips?
Phaco tips, tubings.
Yeah. So tips and sleeves, as most of the surgeons here do, we change for each and every case. And what we do differently is that we have big set of these tips. So we don't autoclave, we generally do ETO of all the tips. And what Ravindra sir has mentioned is very correct, that we should not let it dry without cleaning. So what we do is that we have warm distilled water in the cups in the OT itself. So immediately after use, what my assistant does is that flushes that tip and puts it in that warm distilled water cups. So it is always kept wet, and then immediately it is transferred to CSSD department where it is cleaned. And what we use different is apart from using the distilled water and then the air gun, we also use ether to clean the phaco tips. So ether is an organic solvent, and it will dissolve all the organic material if it is stuck. So it is more useful for even phaco probes and IA probes, because I think many studies previously have shown that if there is organic growth inside these phaco probes, it can give rise to recurrent low-grade endophthalmitis. And because of this ether, that also can be dissolved. And ether is a volatile substance, so it doesn't stay inside the tube. So that is something which we do differently. Yeah, we just flush with ether and let it dry, so
Okay.
it just evaporates, and after that we flush with the air.
Do you have
So
to
that
There, or you flush with RO water or distilled water? After ether?
after ether we just let it dry, because it dissolves and then it
Just
evaporates. After that we flush it again with distilled water and then air dry.
Do you have to dilute or you have to use ether
No,
as
ether directly,
Directly.
because it just evaporates. So this is, I think it was earlier also used as an organic solvent, and basically we don't want any organic material to stay inside the phaco probe or IA probe or even phaco tips. And
What
another
about
good
tubing?
chemical to use is hydrogen peroxide. I think
Hydrogen
that is
peroxide.
also quite good, and we use it for all the phaco probes and IA probe, but I think we use it once in a week.
So if
We are
anything
discussing
gets
about
stuck in
cleaning.
your cannulas, Simcoe cannulas, or basically in the IA probe, hydrogen peroxide really works very well. It just takes it away and it eats it away. Enzyme tablets are also available if you want to do that, or even it comes in bottles. But that is to take away particulate.
Enzyme, only issue with enzyme is that if there is a residue, it can lead to TAS.
Yeah, but then you
with
have to, whatever you are
wash,
using,
yeah.
hydrogen peroxide evaporates, as you rightly said, it breaks up. Similarly, ether, but if you are using enzyme, then you have to really actually.
Enzyme, you have to be really careful in washing out. Yeah.
Regarding enzyme, I think Dr. Nirmal can throw some light on enzyme cleaning and ultrasonic cleaning.
Thank you, Santosh. And yeah, I'm here. Thank you, Santosh and Anaga, for organizing this interesting webinar. So, and I've been hearing a lot of variations in the sterilization methods. And during assessment also, we keep seeing so many jugaads and variations happening. All right. One principle we have to agree is the chemical sterilizations are very difficult to validate. Whatever chemical use, whether it's solvable, solvent or non-solvent, organic or inorganic, it's very, very difficult to wash thoroughly and remove it 100%. So whenever we use any chemical for that matter, so you have to wash and try to remove as much chemical residue as possible. One. Second, ideal is not to use. So somewhere between minimal to maximal, we have to optimize and see what is feasible and what is safe. So first thing is to not to use chemicals, if at all use at the most minimal level. And even if you use minimally, that has to be washed as early as possible before usage. So that is one thing about any chemical sterilization. Second, I think some people are mentioning about the various types of autoclaves. In Ofthal, we use a lot of cannulas and tubings. So ideal is to use a vacuum assisted autoclave, whatever class you follow. But class N, which is commonly used, I saw Anaga's compilation of surveys really. We have gone far ahead in phaco machines. We invest $500,000 on phaco machines. Unfortunately, we are reluctant to invest few lakhs on this important equipment in our theater. So we have to see to that you have a vacuum assisted autoclave, whatever name you call. So this vacuum assisted should be able to remove the air or steam from the inner chamber as well as the tubings. Lot of jugads are there. Even the vertical autoclave, if you can add a pump, you can remove the air. Same way, class S autoclave, most of the dentists use. This also you can add a vacuum, and that's what many of the companies are giving. So our people have to understand the principle of any autoclave they are using and select the proper validation method before using that.
Since we are discussing about cleaning of the probes and everything, if a patient is HIV positive or HBsAg positive, what precaution is to be taken? I think Dr. Savitri Sharma madam and TTL sir or Namrata madam can throw light on this.
See, we consider every patient to be infective, not only after testing for HIV or HBsAg. So we have to take precaution with every patient, considering that there can be latent infections in many of the patients. And we only would like the universal precautions to be taken, which is good enough to protect the anesthetist or the surgeon from
Cleaning of
HIV,
instrument, madam.
HBsAg infection.
Cleaning of instrument. I'm talking of cleaning of probe.
Yes, the cleaning, I don't see any reason for doing anything different, because these viruses are very, very fragile. They get killed with any of these systems that we are using, any of the antiseptics. So I really don't recommend anything special to be done if a patient is HIV or HBsAg infected. The gloving, see, all the people, the technicians or nurses, they should be using gloves. So once the hands are gloved and your instrument may be having the virus, it is not going to pierce the gloves and get into the hand. So I don't really recommend anything special for that. But always gloves should be used even by the technicians who are cleaning the instruments and they are working in the CSST. Gloves are must.
I think we do little differently in these cases. Like we have a totally different sets of instrumentation. Even the phaco machine is, separately designated for these surgeries. And after the surgery, the instruments are, put into hypochlorite solution for some time, maybe for 20 minutes. Then we use a chemical sterilizer, as told about. We use H2O2 for these cases to clean up. Then rinse it and dry it. And subsequently, we do a double sterilization for these cases. So that is a precaution we take for this case.
Can I just add one
Just
point
to
here
add-
Dr. Nikhil here?
No,
Yes,
of
yes,
course,
Nikhil, please add. Yeah.
they are the last
so-
cases which are done in the OT.
Yeah,
Because
last
after
case.
that, we can't do
So-
anything else.
So Nikhil wants to
What
add
I
something.
do in my clinic is, because the staff may also be worried about HIV and all those things. So whatever is used during the surgery is put back into a drum. The drum is closed and it is autoclaved. Then it is reopened after autoclave, and then whatever washing, cleaning, everything is to be done. Because it's such a heat labile virus, we know now that it is perfectly, there is no chance of any HIV surviving there. So I just myself put everything into the drum so that the staff is not worried. I tell them, you put it into the autoclave. Once it's autoclaved, it is free of the virus. Now you do whatever re-cleaning and washing or anything further which is required, or repacking it in proper way for the next surgery. So I do it this way actually.
Just to add a point here, I think for HIV or HBsAg, we need not take any additional precautions other than what Madam mentioned, standard precautions, and follow the universal precautions. Just to add, there are NACO guidelines for HIV, which is again stigmatizing these patients, segregating them to the last of their theater or using a different set of instruments. We need to use the same protocol for all patients, irrespective of their HIV or HBsAg status. You just have to follow the guidelines for every patient.
We are talking of cleaning of instrument.
Yeah.
Hoping you would say that because every patient, we are not knowing which patient is HIV. Every patient is suspected or should be suspected of having an infection. So we have to treat ourselves. No, I was hoping that Dr. Nirmal will say this, because that's what the microbiologists believe, that there is nothing special. Normal way of using antiseptics is good enough to take care of these viruses. We are overdoing it if we are doing it more than that. Could you hear?
Yes,
ma'am.
ma'am.
I think we are
We are
doing
overcautious actually.
Yeah, overcautious.
Better to be cautious then.
Yeah, we are overcautious,
So we use
and
disposable,
they don't really need.
Madam.
we the way we
Your voice is
And
breaking,
every
madam.
No, we can hear you,
patient is
Namrata.
potential commercially
Yes, ma'am.
effective.
Yes, ma'am.
No, basically the way
And we don't test every patient.
Okay.
So basically, the way we used to do during the COVID time, wear those shoe covers also and wear everything,
Yes.
and disposable gown and double gloves. So that is the way we do, and we take it as a last case because after that, nothing is done in that OT.
Regarding sterilization, nowadays people also sterilize them in pouches and then preserve them. So, Dr. Haripriya ma'am, I wanted to ask you, suppose we are doing that, for how long actually can they be kept and you can use it after how long?
So if it's going to be autoclave, then it's 24 hours, as was mentioned by the other faculty. ETO will hold good for 1 month.
1 month.
Yeah, same. We also do that. Any plastic cover is usually a double cover of plastic. So we keep it for 1 month and we write the date on that so that you don't miss that. And also we look for any break. If there is any break in the cover, then it has to be redone. Otherwise, 1 month.
So the ETO
No, but
is
all our tunnel blades are ETO sterilized or autoclaved or whatever. When you get original packing, that has a shelf life of probably more than a month. It's at least a year, I'm sure.
More than
So when
most of
you
the
put it in
vendors-
a, yeah,
most
so
of
when
the
we pack
vendors
it in
give
the
it as 1 year.
conventional plastic, it may be 1 month. But if you pack it in the exact
Yes, our packing
material,
may
it
not
should be longer.
Our packing may not be as good as what we buy.
Because in multi-specialty hospitals, they do double packing and the expiry date which is written on those packs is of 1 year.
1 year, yeah.
So usually it is 1 year. So
No, most of the vendors, ETO packing is, the validity is for 1 year, irrespective of the storage conditions. So in our hospitals, we need to see the storage conditions. See, many of us don't use the continuous AHU or HEPA filter area. So that's the reason why we advocate autoclaving just before or the previous day, where we are very skeptical about the storage areas. But we have a standardized storage area and double wrap package, and if our staff are able to identify and store them properly, then we can have validity even up to 6 months, the autoclave pack. So
Yes.
we have to design the storage policy for each hospital as well as their infrastructure as well as the number of cases they do.
So basically the validity depends on the packaging, because once you sterilize anything, if there is no organic material inside, nothing should grow in it unless there is a physical breach. So
Yeah.
ETO, if you have double pack, for years, it will be sterile. It's just for our own, satisfaction or some rule. We keep it at 1 year or, I think most of the IOLs ETO sterile are for 3 years or more than that.
Yeah.
So it's just for our mental satisfaction, but as rightly pointed out, physically it should be intact. So double packing really helps, because even if there is a break in the outer pouch, you have inner pouch which is intact.
Yeah. And one more thing is where you store. So many of the storage areas are dark, moist areas where the humidity is differential or very high. So you have to ensure that the storage area is dry and also well lit, and the staff frequently visit and inspect the outer cover.
And the sealing method should be always checked. It should be perfect sealing. We should not compromise in the type of sealing that we do.
Correct.
I think also these single-use products, when you package them, it's good to mention as to what is the number of times it's being used. Example, if you're using anti-vitectomy probes, and we always put this is the 2nd time or 3rd time. So we also mention the date, and we give a code number, and we also mention number of times. So the surgeon is also aware that this has been used for X number of times.
Correct.
The protocol says that your reuse policy for single-use devices for that instrument, let's say for vitectomy probes, is about 5 times. 6th time it is discarded. So the whole team is aware once you mention that also on the ETO packing.
Yeah, that's a very good idea. Dr. Saurabh, you mentioned that you are ETOing your phaco probe instead of autoclaving, right? Was it to increase the life of the probe or any other reason?
Yeah, both the things. I think ETO is more effective than autoclave per se. I think
If
once
you compare
anything,
that with the B class vacuum that we were talking about,
yeah,
now then there is the third option now available. So it more confusion in the minds of people.
yeah,
But ETO has more risk of TAS as well. If there is any organic material which is there inside the lumen, which is not cleaned properly,
So, but then there
can
is
be
no,
deposited.
yeah, air also removed, no, in ETO. Then how?
in ETO
It has to
everything
be
is
very
removed.
dry. The
Yes,
instrument has to be dry before
right.
sending.
So it's preferable to have a air gun. So air gun is very effective in drying all the instruments, including the tubings. So
Thermolabile instruments, ETO is good, but which are resistant to heat, like hand pits, we can do
yeah, both.
steam sterilization.
Yeah.
Maybe vitrectomy probes you can ETO.
Yeah.
But other things, yeah.
I think probes also, it's important how we clean them before we send it
Exactly,
out
yeah.
for cleaning.
Yeah.
So we ensure that we run it in the cup of ringer lactate. We run it with vacuum for at least about 2 to 3 minutes before it is sent out. And this is done within 10 minutes if possible. That helps to remove out all the viscoelastic or whatever vitreous lens matter which is within the probe, which is so fine. These small probes, the chance of this kind of it will compromise sterility. Second, it will also become inefficient. It won't work after a point. So you have to do it immediately, then send it out for further cleaning and packing.
I wanted to mention about plasma sterilization, which is very good because it is a very successful vacuum. The very, I should say, extreme vacuum it produces and takes out all the liquid or any fluid anywhere in the tubings. So if somebody can use that plasma sterilization, it's very, very good for the tubing materials.
I think it also helps prolong the life of the handpiece.
Yes,
and
yes,
it is,
because
it
it's
is,
old
yes.
one. Yeah.
And I think it is much more, it's much cheaper than what it was earlier. And 3M, I think I'm using a couple of these Korean ones.
Chinese company also comes.
Taiwan, yeah, either Taiwan or Korea. I'm just confusing, but they're giving pretty good results.
So the one which we have is from Johnson & Johnson, the plasma sterilizer.
They are very expensive. 3M and Johnson & Johnson are very, very expensive and they're pretty large. So this, they've got it for ophthalmology, but I think people from Delhi and Deepak from Cathal, they are selling it. So I think they're pretty good. They cost about 10 lakhs or 10 lakhs or something.
So are you using it specifically for phaco handpieces only, or?
I use it for everything because the cycle is very small. So even for vitrectomy and all we are using, and for phaco specifically, yes, because ETO, the tubes gal jati hai, that not the tube, I mean the wires.
And ETO being a gas, if any liquid is there, it will not sterilize in that area.
So plasma is not very expensive. The only thing is there's a pellet cost. So that's the only thing that you have to see so how much you are putting it, but I think it's about 10 lakhs. That's what we bought them for.
So one question about plasma, does it have a class 5 indicator with plasma?
They have
that was one of the concerns.
Yes. I don't know whether it's called class 5 or class 6, but it has a indicator that gives you.
Has indicator. With every cycle, you need to put the indicator.
Sir, for ma'am, just wanted to ask, for fiber and liquid, you can't use ETO, no?
No, liquid you should not.
For liquid, you cannot. You
And
cannot.
for fiber, what about for fiber? If
fiber meaning what?
Meaning suppose cotton, cotton fiber or whatever can
no.
Cotton,
linen.
Linen, ma'am, we can ETO, but only thing is that with linen we can ETO, but only thing is that there has to be sufficient aeration time, particularly with linen. Otherwise, it will produce an allergic reaction.
Okay.
So at least seven days of aeration has to be there.
So why 7 days? You get these aerations which comes along with the ETO. So if you are, that's a positive pressure, that's a aeration that happens. There's a cycle to it and you have to go through the cycle of aeration. If you don't go through the cycle of aeration, if your aeration is off, then you get a lot of, then you can get TAS and everything. So aeration is mandatory. You have to reach out whatever ETO is left. So that is why the aeration, and if you actually keep it out and as he said, for 1 week, you just let it be. that in itself is an aeration. But otherwise, if the machine has the cycle that has, I don't know, a couple of hours in it or whatever, 60
Yeah,
minutes.
6 to 7 hours mechanical aeration is available. So.
Yes, yes.
But I think it doesn't make sense to sterilize linen with the ETO.
True.
It doesn't make sense because
Yeah.
it will get absorbed and the type of, I think you should read up what can be sterilized in ETOs. It is usually metal, plastic and other things rather than linen.
Okay.
Ma'am, what happens is that in case when you are doing these iPads, etc., if you want them to be single, as a single pouch, that can be done, and after
Yeah, that can be shown.
Yeah.
Plasma that we have has 28-minute cycle or a 45-minute cycle.
That's
Rate is very fast.
That's pretty good.
Regarding the instrument cleaning, one thing that we wanted to also ask is regarding the ultrasonic bath, that tub or the cleaners. So is it mandatory to use that, and how do you clean the cleaner? Because otherwise there could be residues or it could be dirt at the end, which can in fact produce more tasks. So
we have a lot of experience with using ultrasonic cleaners. We always use them, and you need to clean the whole thing. It's actually a small tub, like you can always clean it, scrub and clean. And we use this 3M enzyme in that, so it does not allow anything to settle down. And every 3-4 cycles you can clean it. It's very easy to clean. Should not avoid the cleaning at all. You must clean and then use it. It's a very good thing actually to use.
So you would clean it with the enzymes, with the
already enzyme is being used. You can
Ultrasonic tub, madam.
rub the tub.
But then that also needs to go off. Otherwise, if there's some residue, then again for the next batch of instruments, it could be.
No, but you can
done at RP center, madam.
And we clean it with the distilled. That's what I was told. I mean, I don't know, but I inquired about this. They said they clean it with the distilled water and they allow it to dry before using first they use detergent and water, and then they use distilled water, and then they allow it to dry.
Actually, if you are cleaning when they are moist, we don't need additional equipment at all. So most of the time. So if at all, if it is soil, a lot of blood and viscoelastic substances which are difficult to remove, then we are advised to use ultrasonic cleaner. But generally, not suggested to use any enzymatic tablet because the residues are very difficult to remove. So even after 3 rinses or 4 rinses, there are still some residual material which can cause TAS, and even the AAO TAS advisory doesn't recommend this ultrasonic cleaning or enzymatic tablets. So we have to really caution our members not to use this chemical enzymes or this chemical material unless it is warranted or necessary.
But Dr. Nirmal, what is the harm in doing ultrasonic cleaning? Leave aside enzymatic, that we have said that needs the thing, but
ultrasonic can be done, sir. But the usage of chemicals and enzymes, and some people add betadine to the ultrasonic fluid. So that actually becomes difficult because once it goes into the tubings, it's very difficult to wash.
Ultrasonic is a mechanical agitation only. It's a mechanical agitation which is taking away the particulate matter or whatever is sticking. It is not doing any disinfection, or it's not doing any sterilization. That's the second part of it. It's just to remove the residue of the solid, like viscoelastic is getting stuck or some lens protein or whatever it is. So it will just take that off. And
it's not used for tubings. It's not used for
it should not be used for tubings.
Because you can't, it's a small thing, you can't really put a tube into it, right?
Yes.
No, there are people, sir. There are many variations in the sterilization methodology. So maybe CFS methodology would be different, but there are people who use put the entire set into the ultrasonic machine, add betadine and whatever chemical comes into their hand, and then literally boil it. So yes. The ultrasonic cleaner is set at 20 minutes with so much fluid, betadine, and the ultrasonic, the enzyme cleaner tablet, and the whole set is put inside that. So they believe that it is clean, and they argue that it is because so many mechanical, heat and chemical, everything mixed up is used. They say that is much safer in their hands. So this is the wide variation in the way we sterilize.
Okay.
I think it is getting more and more confusing because there are so many different ways of doing it.
Ideally, it should not be used, ultrasonic cleaner.
Yeah.
And if at all
Ideal
you're
is
going to
not
use
to
it, you
use.
should not use enzymes in it.
No,
Yes.
I would, may I say something here?
Yes, sir.
We're learning more of what we don't have to do.
No, exactly. That's what need to be focused.
No, I think Dr. Anaga, we have a protocol of putting all instruments into, there is a specific tub, 4-liter tub that we put it in so it doesn't dry there. From there, we lift it up and put it to ultrasound cleaner as a routine. Everything goes into the ultrasound cleaner. Why the plastic tubings and plastic things don't work is, see, the metal will have to vibrate at certain frequency. The plastic will not obey that, command of vibration. Not that plastic should not be put, but it's ineffective on something that's there in the plastic. The metals should not touch the floor of the tub. It has to be floated in a basket. And if you if you put weight on the floor of it, then the piezo crystal that is inside will be ineffective. So it has to, the waves have to come in and hit the instrument which is sitting in a tub. And the best is to warm distilled water or warm RO water. It's got a temperature setting. Every ultrasound has got it. You can do it at whatever temperature that you're comfortable with. 10 minutes is the cycle that we use. 10 minutes, and then the tub can be cleaned at the end of the day with just plain water. That's good enough. Or you can use neutral detergent, very small quantity of it, and enzymes are not used. Enzymes should not be used at all, as it's highlighted in ophthalmology.
But which detergent, sir? I mean, detergent also may have some residue.
Best is not to use.
Powder detergent, liquid detergent. Which
we did some tests, but then neutral detergent is there in the, but we generally try to avoid it. Best is to wash it clean and wipe it dry and keep it for dry, so that no organisms grow. Anything that's kept overnight should be absolutely bone dry. That's the
correct. So the betadine is not even used even for the cleaning, right?
Never. Betadine is not used on the instruments at all.
Not at all.
No need.
Yes.
No need.
And what about the soft brushes that are used to clean the tips of instruments?
Special soft brushes
Is
are
it
available.
a routine toothbrush? Some people use a routine toothbrush.
So it's very difficult to use your toothbrush. Very difficult to use the instrument. There are specific brushes you can hold it. They're very soft. They're meant for surgical instruments. You can comfortably clean the instruments with that.
And a new brush every day, or a same brush in how many days you can use?
Brushes, these brushes are very, in Western country, they throw it out every day, but we should not throw it out. Wash them like anything else and dry them and keep it overnight. Nothing happens. See, the moment they are dried, they're safe.
Dr. Ravindran, these are dentist brushes only. They are the ones that bent, which we started using with the Hansotome, because that goes into the crevice where you put the where you put the blade. So those are the small things that those are used by the dentist also, when in between cavities or in between the two teeth, etc. You can put it. So they're just very small. They can bend like this, and they have small bristles. It's not unlike a toothbrush, but it's a very gentle thing that we use to, and that we use specifically. They wanted us to use Colgate Palmolive shampoo, 1 drop in a bucket, not in a bucket, in a tub, and then you have to put it and do that. And only with the alcohol, that the motor has to be cleaned, and not with anything BSS or anything, because that goes and corrodes the motor. So for that specific thing, that is when we purchase those small little brushes. They're easily available from the dentist, this thing.
Okay.
Yeah.
So let's move to the next question.
Yeah.
About the ETO, madam, ETO, see, it's a dictum that anything that can be autoclaved should not be ETO. That's a dictum that most of the people follow, because ethylene oxide gas is very harmful to the environment. It's harmful to the ozone layer that we have at the top. So the best is to minimize use of ETO to those instruments which cannot be autoclaved.
The ETO is actually getting banned. It's actually getting banned for the environmental.
ETO is banned in many countries. Yes.
Yes, it is banned in many countries. It's noxious, and then they say that the outlet should be outside, much above. It should not
20
be,
feet above the human dwellings. 20
It is
feet.
also carcinogenic and it is
Yes.
explosive also.
Yeah.
Yeah.
Explosive, I
So
didn't know.
only
Carcinogenic.
should be used for thermolabile instruments, which will get damaged because of heat. For that only ETO should be used.
Dr. R.D. Ravindran sir, you were saying something?
Yeah. The point I wanted to make is within Aravind, for the last 10 years, we don't use any chemicals, either antiseptics or enzymatic cleaners for the cleaning of the instruments. The only thing we use is RO water. The RO water is again, is filtered through a 0.2 micron filter. So that is made by a company called American Membrane Corporation. So that's really as good as distilled water, because the TDS is very, very low, very negligible. So that's the water we use, either for cleaning or flushing, or for ultrasonic bath or cleaning the ultrasonic the bath after using it. So we have stopped using it for a very, very long time. So, and we don't have, fortunately after that, we don't see any, the cases of TAS is not there almost, yeah.
But Dr. Ravindran, I for a moment thought you are going to manufacture oro water.
Okay.
I heard that as oro water.
If you are many people use RO water, but they don't use this membrane filter. This membrane filter.
I was saying AURO, commercially available oro water.
Sir, you are giving him business ideas.
Yes.
You should patent
So
it.
actually about the chemical disinfection, I go back in history in RP Center. I don't know whether Namrata had joined at that time or not, but when we used to do chemical disinfection for our Simcoe cannulas and the Rajit Singh cannula, I think that Savlon was being used and the sister did not flush, and there was a I still remember one chief minister also, and that the flushing was not done. Everyone developed bullous keratopathy because it just blew up the corneal endothelium. And this was the chief's cases. I think about 10 cases were gone. All the surgeries that were done, and just by a simple mistake that the thing was just taken out and it wasn't flushed very well, and this Savlon which was being used, it just blew up the corneal endothelium. So that's very, very important. I think nobody is using the enzymatic
And same way glutaraldehyde also. So many people are still using glutaraldehyde for the blades and the instruments. So this has to be avoided. If at all, one advisory point is not to use any chemical sterilization.
Chemicals, yes. So now let's move on to the class 1, class 2 and class 5, class 6 indicators. Dr. Saurabh, can you just give us a very quick overview on this and what is recommended?
I think we just need two types, class 1 and class 5 or class 6. They are similar. So class 1 is basically to understand whether that particular package is processed or not processed. So because it is cheap, so we can put it at multiple places and over the surf or the on the package also. And class 5 indicators we generally use in each and every packet which is there inside whatever, whether you are using ETO or a B class autoclave. Inside every small instrument pack, that class 5 indicator has to be there. So first thing that the assistant checks is that whether that is processed or not by seeing the class 1 indicator, and then it is opened. And once the assistant opens each and every pack, he has to look at the class 5 indicator inside, whether it has turned, it has passed or not, and then only he should use those instruments. So I think that's the I think take home message, because that is like the final end point. Even for phaco probes, what I do once I walk in, for my phaco surgery, the first thing I ask my assistant to show me is two things. One is the class 5 indicator of the phaco probe or IA probe. And second thing is the helix test, whether it was put in that or not. So once it has passed the helix test and it has passed class 5 indicator, I am sure that the sterilization is complete.
You do helix test for every set.
Yeah, every tube or long lumen instrument that we use, we make sure that helix test is added in the same the cycle, because that indicates once the helix test has passed, that means entire tubing is definitely sterile. So I think that is also one of the very important things while sterilizing any tubing, whether you autoclave or you ETO, you use the helix test along with that.
How do you do that helix test?
So we have a 1 meter long helix tube, which is basically similar to a vitrectomy tubing or phaco tubing. And at the end of it, there is a this place for keeping the indicator inside. So we keep the indicator inside and it's closed completely and then put along with the cycle. So once you take out the load, you open that indicator part. Whether if it has passed, that means the entire gas or autoclave has been done through the entire lumen.
Okay. In addition, we do biological indicators.
Yeah. Biological indicators are absolutely useful for making sure that whatever machine you are using is actually working. But the problem is that we cannot use it immediately because it takes 24-48 hours. So it's for continuous monitoring of the working of that equipment. And of course, yeah, that is very useful for money. And apart from that, BD test is very important. I think many people don't do that for autoclave. Bovidic. So every day, the first cycle you should run with the Bovidic. That means on that day, the vacuum is being properly done.
Yeah.
Dr. Ade Ravindran, sir?
We just follow what Dr. Saurabh said. No? We use the class 1 and class 5, and we run this Bovidic test every day when we start the day. The first cycle, we use it. So
between class 5 and class 6, both are okay. And
we use class 5 for all of that. And as you mentioned, every set will get a class 1 and every bin gets one class 5. Yeah, and every load, and we also have one for every load also. There is something kept outside, which is the people will know even before, even without opening the bin, they'll be able to know whether it has been autoclaved or not.
So if you look at the documentation of all this, what is the ideal, Dr. Titial sir and Dr. Haripriya ma'am? I mean, how is the documentation kept for all these the indicators and all kept by the staff?
Yeah, I think that is which is extremely important. I think documenting is very critical. One, for the surgeon and the team to know that the correct process has been followed and the gauge has, the indicators have changed color. So before we start the OT, then the surgeon will normally sign it off to know it's done. But like as was mentioned earlier, we also have like once a week we have the indicator. So all of this is also checked on a weekly basis by another doctor who's in charge of the CSST. So besides having the doctor check the steady gauge and the 3-line indicator every morning for the sets which have been used, everything is also reviewed on a weekly basis to ensure all the indicators are checked. It's not just the indicators, but documenting everything, right from the culture, the OT culture, or the water, samples from the raw water, samples from the RO water. So all of this, the temperature monitoring, so everything has to be documented. So documentation is an extremely critical aspect, which has to be reviewed and followed up.
According to me,
Lalit Verma, sir.
Can you hear me?
Yes, ma'am. Yeah.
Yes, ma'am, we can hear.
Yeah, see, according to me, the purpose of documentation is to be able to trace any patient who gets TARS or end-off or any infection. We should be able to trace which autoclave or which instrument set was used for the surgery of that particular patient. Only then you can find out whether that autoclave was working or not, or who was responsible for making any mistake while uploading the autoclaves or taking out the things or noting down what was used for that patient. Unless we are able to trace that, the documentation will not help us to find out why something happened and what went wrong. So I divide it into 3 stages. Documentation in the OR. The technician should be having a register where he writes down first load, which type of packages have gone in. And on every package, there should be mentioned which load it was. Was it first load, second load, third load, whatever? That must be mentioned on every package. And then the indicators which went into that particular load should be stuck on the register to indicate. These are all medical legally very, very important to show that the indicator did change color for that particular load. And this was the tray which was used for this patient, whoever has met with the infection. That's the documentation, and the name of the technician, time, everything should be written in the register. The second documentation in the OR, when for every patient you have operated, you need to have full mention against in the register or wherever in the computer or register, which load was used, again, which autoclave was used for that particular load. You should be able to trace, you should be able to correlate. And the third one is laboratory. Whenever you have sent these indicators, let's say biological indicator, you have sent it to the laboratory for testing, what was the result, and that date and everything should be matching with these other two things. So 3 level of documentation is very, very important to correlate and to later on use it for any untoward infection or any untoward event that happens. So that's how we go by.
Yes. Dr. Lani, sir, in the recent incidents this time, so there were so many incriminating agents. So it could be the lens, it could be the visco, it could be the BSS. So when we are talking about documentation, then are we supposed to document what batch of BSS and visco, even the blades? So there are so many things to document. So I think the surgeon would finish a case in 5 minutes, but would take half a day to make this documentation. So what exactly is recommended?
For the routine cases, documentation is really not required. Only thing is that you can write this lens sticker, you can put it. Other documentation, what batch we are using, what batch this we are using, because there are so many things coming. So the sister is there, she can write the batches. See, you have to write down the batch of tunnel bed. You can write down the batch of visco. That is very, very important, and the things which we are using. But once if something goes wrong, that day, you should not change anything in the OT. You must collect everything from the OT, and that should be sent to the FD. So that is very important. So whenever you are writing the batches or we can say the documentation, the documentation important is fumigation, what you have done, what are the reports of the fumigation, autoclaving, yes, it requires that when you are done the autoclaving, and then the lens what you are used, and few things what is required. But up till now, what I have heard is that plasma sterilization, ETO sterilization, B vacuum sterilization. See, all this thing is possible in the institute. So how many people are working in institute? Maybe you can consider maybe a 40% or 50%. But the individual person who is doing phacoemulsification, how he can have a plasma? And secondly, other thing is you can say whenever he is using, what he is using. So he is not using the packing. See what he is using, he has got some drum, he is putting that in the drum. And we are saying that after 24 hours, you can use that autoclave, this instrument, which is very wrong. See, if he is using packing, okay. Then in the packing, we are using after 3 years of sterilization, we can use it. But if there is no packing and he is using in the drum, we must advise that he should do in the morning, autoclave in the morning and then use. Otherwise, what happens? The message will not go properly. So we are talking very high-fi. It is not possible for the general practitioner to do it. So we must also guide to the general practitioner ki Baba, if you are doing the phacoemulsification and you are keeping that probe in the drum, do it in the morning. Even after completion of your this one OT, you do it that day, and second day morning you do the autoclaving and then use. So what happens? It is the safety is there. So packing is not possible for the general practitioner who is using phaco. Yes, it is for the, you can say, the good practitioners of the institution, it is possible. So we must guide them. So that is also important, because task where from we are getting? We are not getting from the institution. Tasks we are getting from the individual practitioner who are practicing. And so we have to guide them. And it is not the material that we are getting from only IOL of the lab like that. No. Out of the 63 patients, there is not a single IOL from the eye care that we have got the patients in JJ hospital. There is no any I will use probably lal. So there are some different type of IOLs are there. It may be something now somebody saying it is a visco or it may be some other thing. So we should see that whatever goes inside is important. So I think we must classify that may be one IOL, that may be visco, that you are using the, you can say the balance salt solution, somebody is using RL. So many things are there. So we must guide the people who are really working in the interior. Interior, you can say the districts and all other places, because this webinar is for the people who are in Maharashtra or in India, not in, you can say, metros or like that. So also we should guide them that yes, if you can afford, go for plasma, go for YouTube, or go for the B class, you can say autoclave. If not, then autoclave in the morning, automatically everything will die and it will be easy to operate. So that is what we should guide them. But I feel.
Yeah. So freshly autoclaved instrument should be used. Your opinion is that freshly autoclaved instrument should be used.
Those who are no, if packing is not, if there is not a proper packing, if proper packing is there, you can use any day. It is not that you should use on the 24 hours. We are using after 3 years lenses, which was sterilized, packing is proper. But if it is not packed properly, because what we are doing, we are putting in the drum and we are using yesterday's using today. So those who are putting in the drum, they should freshly autoclave use.
Just to add on to what Sir said, just fresh autoclaving, we should first validate whether the autoclave is functioning properly or not. Whether it is, see, the issue is whether it is contaminated, getting contaminated by if you're not packed. That's a different issue altogether. So even if you autoclave in the morning itself, freshly autoclaving, but the autoclave itself is not efficient enough to kill all the bacteria which is gone inside. Even if you autoclave just 15 minutes before you do the surgery, and the bugs which are stuck in the phaco probe have not died, then it may not be good enough. So important thing is also validate whether your autoclave is functioning properly or not. Apart from how long are you going to store it?
There are guidelines also. You should validate your autoclave monthly, if not possible, 3 monthly. You should validate your autoclave. The person who has made the autoclave, he should come. He gives out the guidelines that this is the validation. You must do the validation, and accordingly, and it is very important, yes, that validation of the autoclave is important, and that can be done at any place. So validation and freshly autoclave is used when you are not packing properly. If you are packing properly, yes, you can use after 24 hours or 36 hours or 74 hours, no problem.
You are doing volume surgery, so how do you train your staff?
Anaya, can I just add one
Yes,
point?
yes,
Yes.
The autoclaving validation, Dr. Lahane and Dr. Deepak said is most important, because I'll just give an example. We bought a new autoclave, which has got, the pre-vacuum and post-dry cycles. And the company fellow had given 3 purges. Purges means once the temperature, the vacuum goes up to certain levels, and it purges it again, it removes and goes to the vacuum, and then pressurize, purge, pressure. He had given 3 cycles. And then he said everything is all right, go ahead. Then we didn't believe him. We got a neutral validator, the outside validator come and he ran the empty cycles with Bovidic and all those things. The very leading company manufactured autoclave, and he said it's inadequate. Okay, then he should have a pre-vacuum, post-dry cycle, and possibility of purging. And it's almost impossible if you're doing it manually. It should be automated. Automation is very important in an autoclave. So all the cycles are fed into a controller, which is which operates the entire cycle. There are about 20-30 steps in autoclaving. It's manually, it's impossible. So he increased by one more, purging. That is, the temperature goes up to 121 degrees, and the pressure goes up to 20 pounds, and then it goes to the vacuum cycle and builds it again. So that is to remove the residual air or residual steam from inside, and then it passed the test. So the validation from the company people will be misleading. It has to be validated from outsider. About autoclave, I think being ophthalmologists, all of us should stop using vertical autoclave and should buy, they're not expensive. Indian made imported one, they're all affordable. We should buy a horizontal autoclave with pre-vacuum and post-cycle with auto controller. This is a must for every ophthalmic setup.
Dr. Namrata ma'am, what is your opinion about using flash autoclave? In between, you're muted ma'am. Yeah.
So we do use flash autoclave in between, and the advantage of that is that it is much faster. So for in between the cases, we can use flash autoclave. I think it's not a bad idea at all. And
But for probes and I mean for the tips and tubings also?
No, not for the tips and tubings, but otherwise we do use flash autoclave for sterilizing in between. Like I said, like everybody also mentioned here, we have a plasma sterilizing system from J&J, and we have there are 2 plasma sterilizers we have. So for us, that is not an issue because all the instruments are sterilized one evening before. All the sets, in fact.
What does the evidence say regarding the use of flash autoclave?
Flash autoclave has to be avoided. Recommendation by CDC and all AOR and all the authorities on sterilization. It is to be avoided in most scenarios, except emergencies where a very valuable or essential instrument is dropped or we require for the surgery. That's the only time it is recommended that you go in for a flash. Basically, just to clarify, flash autoclave is supposed to be done in an unwrapped cycle. The instrument is not wrapped. Why we don't want to be used regularly? Because it's an unwrapped cycle. The possibility of contamination during transmission from the sterilization to OR room, that's the issue. That's the reason why it is not recommended as a norm. Only in case of emergencies, you can use it, but not. But some surgeons have made a jugaad, like they keep the flash sterilization in the autoclave itself. So the transit time contamination can be minimized. That is one of the thought processes. But as a general rule, a recommendation, I think the flash sterilization is something which is to be avoided unless it's an emergency situation. That is the recommendation by all the guide.
Suppose you don't get your linen one day before, or you don't get, you have to do it in emergency, then you can do it in a flash autoclave or drums to sterilize, which you have not got it on the same day.
Yeah, mainly for, I think, solid instruments, like toric markers, which are maybe you have less in number, or some instrument which has fallen down and you want it immediately. So like Deepak
Not
said,
on a regular basis.
only for emergency sterilization. In fact, I was reading about plasma sterilizers, and actually it is approved only as an emergency sterilizer. Nowadays, I think companies are pushing it as a regular sterilizer, but I think initially it was approved only as an emergency sterilizer.
Plasma sterilizer is too expensive to be approved only for emergency.
Regarding the flash sterilizer, I think in 2015, the American ACRS permitted the use of these in the ophthalmic OTs. So I think it is permitted to use between cases. Most, I think, guidelines now say you can use flash in an ophthalmic setup.
But there are
I think
reports,
Namrata, I'd like to clarify, the autoclaves we are using in or OTs are not flash nowadays. Those are almost 5-6 years earlier.
Yeah.
Now they are proper sterilizer, which takes almost 20-minute cycle. And they are wrapped instruments are kept inside. They are basically for all these scissors and this thing, because we don't sterilize a sharp instrument. So they are wrapped into the clothes and then taken out.
So,
Actually, the name itself is
Sorry?
Can I say something?
Yes, ma'am.
There are reports of developing tasks after these flash sterilizers, because pseudomonas can develop inside and endotoxin can build up in the water, which is used inside that, because that water may not be removed regularly. And though the organism may not be alive, gram-negative endotoxins can be present inside the flash sterilizer. Those were the reports which led to actually a recommendation not to use flash sterilizers.
Okay. We'll move
just to add a point, I think the flash sterilization name itself is a misnomer. It's actually immediate use steam sterilization. And previously, what Dr. Savitri Madam was telling was the previous set of flash sterilizers. They were supposed to be kept within the theater. And when the people don't change the water or doesn't use the proper water, there is a risk of contamination. But nowadays, this IUSS, immediate use steam sterilization, comes as class S or class B itself in a that has to be kept within the, now it is called as dynamic air removal sterilizers. So that should be kept within the sterile area and can be used. As Dr. Haripriya said, it has been approved for usage, but it has to be used on the same day immediately.
Also use the high speed, as Haripriya mentioned, we call that high speed autoclave.
Yeah.
I think it goes within like 20 minutes. And it's unwrapped, all the instruments are unwrapped, but they are kept inside a sterile bin and we use it immediately. Yeah. But it's not meant for storage.
Yes, same day usage.
Yes.
Yes, indeed.
Regarding the use of, we move on to the intracamerals quickly. Regarding the use of intracameral antibiotics, Dr. Haripriya, madam, we know that intracameral moxifloxacin, for example, is a very important usage for the prevention of endophthalmitis. However, if we look at it from a different perspective, like in TAS, do you think if you inject a little bit more, would it cause TAS?
Yeah, so I think the dosage we injected is 500 mcg of the drug in 0.1 ml. So I think Steve Ashnaf says you can even use like 150 microgram and you can use about 0.3 to 0.4 ml. So about 500 to 600 microgram is what is normally recommended. Now, with increasing the concentration, yes, there can be a chance of TAS, but more a chance of endothelial damage and more a corneal endothelial damage kind of a picture. Now, TAS can happen if you are having issues with the dilution itself. That can cause the TAS picture as well. We have various doctors who go up to 1000 microgram as well, but I think most papers use about 500 mcg of the drug.
I think there was a advisory from the ASCRS also that moxifloxacin, if not used in right concentration and right dosage, can cause TAS. So one has to be careful about it. This had come just about a month ago.
So what is the ideal way of injecting moxifloxacin, if at all you are going to use it?
So I think thankfully in India, we don't have the issue of dilution because we have many companies who make it refilled or, like we draw in about 0.1 ml. So you can just use it directly in the eye. So there is no issue. I think in the US, they'll have to dilute and that has a higher risk of endophthalmitis.
So again, I don't think there is any issue of whether you inject it near the wound, from near the wound, or you go right into the pupillary, near the pupillary area and inject it. But there has been, discussion even about that, where you should inject it.
So I think Dr. Ravindra raised this point. I have never had this kind of a situation. If it has been injected right at the wound and pushed it in, actually I put moxifloxacin in my LRIs also. When I have done an LRI, when I have just opened it, I put moxifloxacin with the cannula inside. And I have never had any problem whether I have put it into the bag, gone right in there, put it into the bag, or put it at the pupil or some time, because it's just, you just put it 0.1, and even if it had put at the incision site. I don't know, Dr. Vindra had pointed out in one of the sessions earlier, but I don't know what others have felt, but I have never had a problem of TAS, even if I have not injected in the pupillary area.
I think also that, it's difficult to go up to the pupil sometimes, especially if you have a larger side port. When you go all the way and inject, the chamber will collapse. So it's easier to have it at the wound. So that is, I think, that's what we would do. Just make sure you hydrate the wound so the drug will stay in the eye. That is a possibility. We have used intracameral moxifloxacin now for the last 8 years almost, and about close to about 24 lakh eyes injected intracameral moxifloxacin. And we have not seen any cluster or any TAS which is linked to IC moxi in these last few years which we have been using it.
If we look at our survey, almost 50% of ophthalmologists even today are not using it routinely. So I think maybe that fear of TAS is there. And I think we will need to give a proper advisory or a recommendation. I know it is still the individual's choice, but
So if you look at the AIOS survey that was done recently, 40% of them are only using intracameral.
Correct.
In
Correct.
60,
So
the rest
that's
is not.
40-50% is about the same. I think some
Yeah.
people feel that they don't get end off otherwise, and the other people just want to put in that extra bit of safety.
Yes.
So that's about it.
So if we move on to the irrigating solutions, there are people who are still autoclaving the irrigating solutions. Is it recommended? Any evidence-based thoughts? Dr. Frederick, sir?
I don't think it is recommended.
It's not recommended, and even the manufacturers do not recommend tampering with their package. So generally, we are not supposed to tamper with their package as per their instruction for usage.
Okay.
The second thing, whenever any fluid is heated or re-sterilized, the pH alters. If it is viscoelastic, the viscosity alters, and so the more adherence to the lumen or the cannula we use. So ideally, any chemical that goes inside, you have to follow the manufacturer guidelines and use as it is.
Even regarding the visco, a lot of them autoclave the vials and then they use it.
Now the pH is altered, the chemical constitution alters. Same way the ringer lactate also, when it is autoclaved, the pH and the soluble substance. The ringer lactate is a highly insoluble substance, so it alters the entire pH and the substances.
See, the problem is that the quality control that everyone has this lurking fear that the quality of the things that we are getting is have we ever thought of autoclaving a Helon or a Viscoat or anything like that? Because the quality controls are so very stringent. Obviously, it's just a mental peace of mind that we are wanting, but the thing should come from the manufacturer. That whatever we are getting is basically there is proof that it is good quality and it does not have endotoxin and it does not have any pathogens. So that is the most important thing, and that is why all of us see, ultimately that issue was raised last time also. It's the ophthalmologist who bears the brunt. So I think it is just a question of saving our skin that we are going on to these things, whether there is scientific evidence or not, because there is no scientific evidence. You can't even the temperature in the bottle of this thing will not go to a level which is going to be of any great use, and then they say you could get micro cracks and things like that, and obviously plastic you can't autoclave and things. So a lot of ultimately I think we should have rigorous quality from the manufacturers when it comes to us. That is the
how do we ensure that, sir? I mean, now we have all the seniors and the AIOS leadership here today with us. So if we have to ensure this, like as you so rightly said, we are only using what the manufacturer gives us. So we can only look at it externally in the light and then use it. And then if there is an outbreak of whether it is STAS or ENDOF, then we go back and say which batch and whether it was done or not. So from the, as the AIOS task force, so just like we have recommendations for us, what steps can we take to ensure that there is a standardization of the products that are being, is there anything that we can do?
There are regulatory bodies are there which are actually supposed to, regulate. And when an untoward event happens like this, then we are supposed to report to the pharmacovigilance. There is a whole department, pharmacovigilance department, and of course the DCGI doesn't come directly into it, but it will also refer its cases to this pharmacovigilance department where these cases are referred to.
But Dr. Nanda, you just look at the recent incident where you had these kids dying because of supposedly because of a cough syrup in the African countries, and then the government comes out and says this is to badnamify Indian pharmacies, pharmaceutical products. That's what the government said. And then when you had it in Uzbekistan, they conduct a raid on the same thing and on the same factory, and then they say that there are problems and the factory is shut down. So, this is within a period of 15-20 days. Yeah, so this is in Noida, or your hometown. So, see, actually,
only thing is it should not take a crisis to.
That is what, despite a crisis in Africa, I have personally heard the interview of the government people saying that, well, this is to pull down the Indian pharmaceutical industry, and it is being said, and there is no evidence that whatever ethyl glycol or whatever was the thing that was there which possibly caused the death. And the same thing came from Uzbekistan. This is like less than 72 hours or 96 hours ago. Noida factory, this thing sealed. So one really doesn't know as to what the authorities or what they do. That is the robustness of the system. FDA conducts raids for or inspection checks for Indian pharmaceutical supplying medicine to US. And they point out so many mistakes and so many fallacies, and they close down plants and they say not to import this, that, and the other. But we haven't heard anything from the Indian FDA coming out of that. That is the problem.
Yeah,
And AIOS
unfortunately,
monitor the products. AIOS as a parent body, can you assess and monitor the products every 3 months or something like that?
that is outside our purview.
That will
One
be
thing is there are good manufacturing practices, GMP norms for all these companies. Unfortunately, it is not implemented uniformly across India. The second thing is the supply chain management. So many of the product need proper supply chain. So our supply chain is lacking. So like vaccine, we need the manufacturer to certify the end user that this product reaches you in good condition. That's what they do for some of the vaccines, right? So we have to insist on this end user agreement between the manufacturer and the user. So that means the doctors, and insist that they give the certification for all products. So thereby, if there is a problem, we can always hold them accountable. And this vicarious liability, which is actually focused on all the doctors, should be given for the manufacturer also. So if there are any issues, the manufacturer and the supplier should be taken to task for vicarious liability. Particularly in this instance, we have a strong case.
There is a question, I think, Anaga, in the.
Yes, ma'am. Would you like to answer it, ma'am?
I don't want to answer it, but I think the question is that are there, with an epidemic of TAS, it's not individual OT protocol under the scanner, is it? Is it true that there are no institutes with the TAS? So I don't know, Dr. Lanis has said that there were no cases of TAS in his institute. And I think we'll take this answer from Dr. Chetial sir to say whether there were any TAS related events. I don't think we also had, sir.
No, in recent time, I don't remember seeing any such cases, individual or in a group. So it would happen to, definitely to some institutions, some practitioners, but something which is happening in a larger number, like which has happened now, we do need to really check what was the actual, cause. Once we know the cause, then corrective measures can be taken by the manufacturers also, because they also need to know what is the actual cause behind these things also. So this is I think, way of looking. We need to assess everything, then actually pinpoint what would have been the culprit and try to correct that.
I think we are almost overshooting the time.
I have a question,
Only
Anita.
left. Yes, ma'am.
I have a question.
Yes, ma'am.
Dr. Lalit Verma mentioned that samples have been sent for testing. I wanted to know what kind of testing. For TAS, cultures are going to be negative. What other testing can you do?
Endotoxin.
We do the endotoxin levels in the related to the lens. Then the lens is generally stored in fluid. So endotoxin levels of the fluid itself, where the lens has been stored, and also these have monomers in various percentages. Like the material would be one, but the percentage of the monomer would be different. And even if that varies, even that can lead to these TAS-like events. So we are testing for all three. And whatever
Do we have labs? Do we have labs which will test this in India?
Yes, so we are getting this tested from the CDCL, that is the CDCL accredited lab, and we have 2 of them in Delhi. So we send it to one of them.
Okay.
I think the manufacturer has to get an endotoxin level done. I think Dr. Haripriya or Dr. RDR can throw light on it. I think Orolab does that. Everybody, there has to be a free monomer content
Yeah.
that has to be talked about, and there has to be a content on the endotoxin. These are the two important. It's not infective, Dr. Savitri, that's for sure. It's basically toxic because it's just by steroid drops, it is gone. Might have taken a couple of days to weeks to 1 week to 3-4 weeks, but it has gone in all, and thankfully it's not infective in any of them. Cultures have all been negative. I don't know what institution is meant by definition as an institution, but RML had it, we had it, other people have had it. It's those who use that particular hydrophilic blend of lens that have had it. RP Center doesn't use them, I think. They
No,
they
we
don't
use them, sir. We use them. We have from the same batches. We also have from the same batches. The batches which were mentioned, we use them, but we didn't have any untoward event.
Yeah, but it's not in all cases that is there. But as was rightly said, there was a flood of it. So it's not. And ever since the usage has been stopped, there is total silence from people that nobody, not even a single person has reported on that. And it's, I don't know whether the company has come forward and given an endotoxin report or a monomer report. Let them come forward and give as to what their reports are. Though they have sent a report of the sterilization, not having any bacteria, that is fine. We all know it's not infective, but as regards the endotoxin and the monomer,
Yeah,
they need.
unless that report comes as endotoxin or monomer or whatever, we cannot be really confirmed what happened and why this has happened.
As per the company, they have sent the reports today, and they got it tested from 3 different labs. And they have emailed it just today, just a couple of hours before, and those reports are clear. So we are anyway sending our report also, and these reports are awaited. Today only we've sent the samples.
Okay.
Thank you so much, everyone, Dr. Santosh.
Yeah, so we had a quite exhaustive discussion on very important issue, and I would like to thank all the panelists for taking out time and taking part actively in this discussion. But we are only halfway through. Tomorrow also we have another important issue which is related to operation theater and patient related issues. So I would like to thank you all for joining this webinar. And Dr. Anagha, would you like to say a few words?
Yes, it was absolutely wonderful to hear all the inputs from everybody and to know their experiences. And definitely, like Dr. Namrata Sharma Madam said, we should know now what not to do. And this is a very good learning experience for all of us. And we will look up to all of y'all because you have all been so experienced, and with the years of experience, all of us will grow wiser, definitely. And I hope this is beneficial to all of us fellow colleagues. Looking forward to a similar session tomorrow again. Thank you so much.
Thank you. Thank you. Good night.
Good night. Thank you.
Thank you so much.
Thank you, Anaga.
Thank you. Thank you.
Happy New Year to everybody. Thank you very
Good night.
much.
Yes, sir.
Thank you, sir. Rani, sir,
Thank you.
thank you.
Thank you for the valuable time, sir. Thank you.
I has stopped.